In this lesson, we will examine the elements of the neurologic examination. My hope is to teach you not only the correct steps in the examination, but also an approach to patient diagnosis using localization from your examination to develop a workable, accurate differential diagnosis. We will go over the components in future lessons in greater detail. There are 8 steps to the neurological examination. It is easy to remember if you apply the steps from head to toe, or in simple terms, from top to bottom. These include the mental status examination, tests of the cranial nerves 1 through 12, the motor examination, testing the muscle stretch reflexes, testing the special reflexes when applicable, testing the sensory examination, the cerebellar examination, and finally, the evaluation of gait and station, including stressed gait maneuvers. Let's start by looking at mental status. The mental state examination begins with your observations as the patient enters the examination room. You should be observing their body language and habitus. Where do they sit in the room? How do they communicate verbally? Do they communicate nonverbally as well? You are attempting to get information about their mood and behavior while simultaneously assessing their appearance. The higher cortical functions you might assess further include the ability to attend, orientation, memory, and might even include abstraction and calculation. Look for perceptual changes and be alert to the possibility of apraxia. You should know the process to examine all 12 cranial nerves. The olfactory nerve, testing smell. The optic nerve, testing vision and pupil reflexes. The oculomotor, trochlear, and abducens nerves test eye movements in a conjugated or coordinated fashion. The trigeminal nerve, testing facial sensation and the muscles of mastication. The facial nerve, testing facial expression. The auditory nerve, testing hearing. The glossopharyngeal nerve, testing the gag reflex and palatal function. The vagus nerve, observing the gag reflex and the patient's phonation. Accessory nerve, testing the trapezius and sternocleidomastoid. Finally, the hypoglossal nerve, testing tongue movement. Often, it is useful to divide the cranial nerve examination into a few component parts. First, look at the cranial nerves involved in extraocular movements and vision. Then, sensation and motor functions of the face, including hearing. And then finally, the oral motor functions, speech, and swallowing functions. Of course, cranial nerves also encompass autonomic nervous system function and the special sensory functions. We will review these in more detail later in the course. Up next is the motor examination. The motor examination begins with asking the patient to stretch their arms out in front of them, and you look for pronation and drift of the upper extremities. This can be a subtle sign of weakness. Drift upward can be a subtle sign of proprioceptive sensory dysfunction, often considered to originate from the parietal lobe. During this portion of the examination, we also look at muscle bulk and tone, looking for muscle atrophy, fasciculations, and other signs of muscle deterioration. We test muscle strength either grossly or much more specifically, depending upon the presenting complaint. You'll also want to test the reflexes. Muscle stretch reflexes are obtained and assessed using the reflex hammer over specific regions. These include the biceps, triceps, and brachioradialis for the upper extremities, and knee and ankle in the lower extremities. Occasionally, we are able to assess hamstring reflexes using the hamstrings biceps tendon behind the knee or posterior tibial reflex, striking the tendon at the medial ankle or its insertion. Each reflex represents a spinal root level and helps you deduce the level of a peripheral problem. There are several special reflexes which we will review in another lesson, but the most useful is the plantar response. The special reflexes are used to confirm subtle upper motor neuron signs which indicate damage within the brain or spinal cord. The plantar response is elicited by using the smallest amount of pressure possible to obtain a response while moving from the heel toward the large toe on the outer surface of the sole of the foot. You observe the response at the first metatarsal phalangeal joint. In adults, the toe will normally move downward, producing a flexor plantar response. If the toe moves upward, producing an extensor plantar response, also called the Babinski response, this suggests an upper motor neuron lesion in the motor pathways or somewhere along the cortical spinal tract. Next, perform the sensory examination. It is sometimes difficult to interpret a patient's responses. Typically, sensation is tested for symmetry, looking for patterns of disruption. It is most important to make sure your patient understands how you want them to respond. For instance, if you are using a pin, ask if they can tell you the difference between the sharp point and a dull object. They might feel a touch and respond that they feel your touch, but you wouldn't know if they can distinguish the sensation type. This is important with all sensory testing, proprioception, vibration, or temperature testing. There are several ways to test cerebellar function. The finger, nose, finger test shows subtle loss of coordination and the presence of appendicular ataxia. It is important to have the patient extend the arm as fully as possible to accurately assess for ataxia. When testing the lower extremities for appendicular ataxia, we utilize the heel to shin maneuver. With the patient lying, you ask them to bring the heel of one foot to the knee of the other and slide that heel down the shin bone carefully. There are other tests that are helpful in assessing muscle tone which is decreased in cerebellar disease. The rebound test can be added during testing for pronator drift. Here you tap the arm downward and assess if the rebound to the original position occurs with overshooting. You can also test checking ability. While protecting the patient's face, you ask them to pull their flexed elbow toward them against resistance and then release it to see how they check the movement. Lastly, you should assess gait and station. This final assessment begins when you first meet the patient and observe them walk into your examination space. You would observe gait speed, cycling, arm swing, balance, coordination, and look for asymmetries. If you do not have the opportunity to observe the patient in that less formal manner while unhampered, you might ask them to ambulate out of the room or in the hallway and observe them. Test their gait, including tandem gait. You might ask them to stand on their toes and their heels to assess distal motor power and balance. Finally, the pull test can be used to assess postural stability and is useful as part of Romberg testing, which assesses body sense and proprioception.